Welcome to the Health Leader Forge, where today's health leaders help to forge the leaders of tomorrow. I'm your host, Mark Bonica, of the University of New Hampshire's Department of Health Management and Policy. Our website is healthleaderforge.org, where you can find information about subscribing to the podcast, links and information related to the episode, as well as our complete archives. Health Leader Forge is a production of the University of New Hampshire's College of Health and Human Services. Today's guest is Kevin Callahan, the CEO of Exeter Health Resources in Exeter, New Hampshire. Kevin has been the CEO of Exeter Health Resources for nearly 30 years. His tenure spans many of the healthcare industry's most tumultuous changes. Kevin describes himself as a person who thrives on the challenge of change, and in this interview he talks about how he has kept the organization adaptable. The original interview with Kevin is 90 minutes in length. I've produced an abridged 45-minute version as well as the 90-minute version. Both the abridged and the unabridged versions are available on the Health Leader Forge website. You are listening to the unabridged version of the interview. If you wish to listen to the other version of the interview, please return to the Health Leader Forge website. Welcome to the Forge, Kevin.
Nice to be here.
You studied history at Seton Hall in New Jersey, and you graduated magna cum laude. Does that mean you were a Jersey boy?
Jersey boy, right. Not in terms of the play, The Jersey
Right.
Boys, but born and raised in New Jersey. 26 years. I spent 26 years in New Jersey. Went to Seton Hall prep school prior to that, and then subsequently graduated from Seton Hall University.
Okay, and you studied history. Why did you choose to study history, and do you still have an interest in history?
I do. I actually have a very deep history. My particular focus was in colonial American history,
Okay.
and in particular, the influence of the British and their sensibilities regarding governance and governments and the impact it had on early colonial thinking. And I spent a lot of time focusing particularly on Thomas Jefferson. An interesting gentleman in our American history, suffice it to say, a brilliant man in his own right.
Yes.
But I also have a pretty deep interest in the history of leadership across the different centuries. And so particularly in the 20th century leadership, I read a fair amount. I have great admiration for some of our great 20th century leaders from Teddy Roosevelt to Theodore Roosevelt to Winston Churchill. Particularly right now I'm focused on exploring and reading quite a bit about the Battle of Britain and Winston Churchill's role in that.
All right.
Yeah.
Great. After you graduated from Seton, what did you do?
Well, when I was originally in Seton Hall and studying history, I kind of dabbled with the concept that I'd like to teach.
Mm-hmm.
But I also had somewhat of a latent interest in law, and I felt as though that an understanding of history, focusing, and particularly American history, kind of gave me a broad grasp of not only the organization of our country, but the organization of its laws and how they were ultimately constructed, certainly from the Declaration of Independence to the Constitution and so forth. And so I kind of had somewhat of an interest in law, but I wasn't convinced either way what I wanted to do.
Mm-hmm.
And so from there, I needed to work. And I knew that if I was going to go to graduate school, either to study law or to study something else, I needed to kind of collect sufficient resources to get myself through graduate school. So I started working in a hospital, and my sister at that time was a nurse. So I thought, well, it's a good place to work. I would kind of figure out where I would ultimately want to go, what direction I want to go in. They paid well, and I knew a lot of people that worked there. And so I worked a summer in a hospital after I graduated.
What did you do?
I worked in hyperbaric medicine. I actually started working there. And now that I kind of reflect on it, I started working there in my junior year of college.
Okay.
A very active scuba diver. Spent a lot of time diving around the Western Hemisphere. That got me interested a little bit in hyperbaric medicine. And so I worked in hyperbaric medicine for probably close to almost 4 years between the last 2 years of college and about 2 years after college. So as I spent that time in hyperbaric medicine, and as a result of that, getting very much enmeshed in the organization of a hospital and how it ran, and I was quite fascinated by it. And I remember somewhere senior year, toward the end of my senior year, perhaps, making an appointment to speak with one of the administrators of the hospital to try to understand what he did.
Okay.
And so we chatted at some length, and that kind of piqued my interest in understanding a little bit more about working in a hospital from a leadership perspective, what it meant, what would be the necessary educational requirements to pursue to be able to fulfill that aspiration. And that kind of pivoted me away from law and pivoted me away from teaching colonial history to considering a career in healthcare management. And there I went.
Okay, so you went to George Washington to get your, was it it was a MA?
MHA.
An MHA, okay.
Yep.
And how did you choose George Washington, and how was that experience?
Experience was phenomenal. It was just a great experience. It was in part constrained by wanting to stay still on the East Coast. I had an aging parent, had a lot of connections on the East Coast. Mm-hmm. Also had a lot of connections in Washington, D.C., for a variety of reasons. And George Washington University, when I went down there to interview, I was just really impressed with the faculty. And importantly, I was impressed by the environment in which it was operating in, specifically the political environment of Washington, D.C. It was vibrant. At that time, I'm thinking back, there was an enormous amount of work that was going on from a health planning perspective. National health planning laws were beginning to evolve. President Carter just come in 1976, so we were somewhat through his term as a president, and there was a lot of work being done from a national perspective in health planning. So it was really a hotbed of really a lot of interesting work going on from a healthcare perspective. So George Washington University being in Foggy Bottom, merely being a few blocks away from the Capitol, and in just an incredibly rich environment, politically, socially, intellectually. It was just a great place to go, and I liked the faculty, and I liked the people that I interviewed with. And so it was a pretty easy decision for me.
Yeah. So you did your degree at George Washington, and the next thing I saw on your CV was Exeter. Did you do anything in between, or did you?
Yeah, I did 2 years postgraduate work in Fall River. You were required, and I still think you are at George Washington, you were required to do a 1-year residency program, kind of an insight to residency where you spent time working in a healthcare environment for a year. My first residency, and you didn't really have a lot of choice in residencies at that point in time, and so I was assigned a residency to go evaluate. And that residency was actually here in New Hampshire. It was in Manchester. And I came into the airport. I think it was about 35 below zero. The city had gone through an incredible ice storm and nothing worked. I was leaving Washington, D.C., where most things worked, but not everything worked. And I was particularly interested in working in health systems that were merging or contemplating going through a merger. And so at that time, the hospital now was a Catholic Medical Center, which was a result of a merged hospital on the west side of Manchester. And so, and I had a great interview there. But there was just something about coming this far north in just what I consider to be really just kind of gnarly weather.
Yes.
And again, being from New Jersey and spending time in Washington. So I was interested in the residency, but not maybe overly enthralled.
Okay.
So I came back, and my professor at that point in time conferenced with him and said, I don't think I want to go there. And he goes, well, I don't think you really have a choice. and I go, well, what does that mean, Professor Ginsig, Leon Ginsig? And he goes, well, there's not many residencies in America, in the East Coast, that involve mergers. And I think you'd be best taking that one. And I said, I don't want to take it. And so he kind of left it at that. He goes, well, I'm going to give you some time to think about it, and then why don't you circle back to me? And so I did. I gave it a few days and kind of did some more thought. I gave some more thought about the environment, both the hospital system and the environment of Manchester itself, and came back to Professor Ginsig and said, I'm not going.
Okay.
And so he goes, well, there's a good chance that you're not going to have the residency of your choice. And I go, well, then that's okay. I'll figure it out somewhere or the other. So probably about 2 weeks later, he came back to me and he goes, we have a residency opportunity. At this point in time, I think he's going to maybe send me to Hades. We have a residency opportunity for you, and it's in a place called Fall River. In Fall River, Massachusetts. I go, well, sounds interesting. I don't know where it is, but tell me about it. And so this was, again, a health system that was merging Union Hospital and Truesdale Hospital, now South Coast Health System, which includes New Bedford and a couple of other health systems down there. And and it sounded really interesting. And so I came up for an interview in Fall River, met the CEO at that point in time, and was totally struck by the opportunity, the intellectual opportunity to really learn about the merging of two organizations, both from a business perspective, an economic perspective, a corporate perspective, but the merging of two very different cultures. Yeah. And so I spent 2 years there. 1 year I did my required residency, and they asked me to stay and do a second-year fellowship there. So I spent 2 years in Fall River.
Okay.
And so, and I learned a lot there, and
that's an exciting time to be in an organization when you're.
It really is. There was a lot going on. It was. I would have to characterize it as an incredibly positive and an incredibly negative learning experience. You saw both the best and the worst of organizations trying to come together organizationally. A lot of organizational infighting. There was conflicts amongst board members, conflicts amongst two different communities. It was really quite interesting to see how two community assets with their own deep, rich traditions were attempting to come together and create one entity. And so I learned a lot from that. But it had also persuaded me at that point in time that I don't know if I want to stay in healthcare. So
really?
No,
okay.
I was going to go back, and I kind of dabbled with the thought of going to law school. So I took my LSATs, did well in them, was accepted in law school, and was seriously thinking about going to law school to do healthcare law.
Okay.
I liked healthcare. I figured I'd be really good on the corporate side of healthcare law. And so before I made that final decision, though, a good friend of mine, which will bring me up to Exeter, who was a executive at this merged health system attempting to complete the merger in Fall River, says, there's an interesting place that I think you ought to go take a look at. I don't know. You might be a good lawyer, but I think you'd be a better hospital executive.
Okay.
Oh, really? Where's that place? In New Hampshire. And I'm like,
not
New
again.
Hampshire. Yeah, not again, New Hampshire. And he goes, yeah, it's a small organization up in Exeter, New Hampshire. And so I say, yeah, let me think about it. I'm kind of thinking I want to go in a different direction. So his office is down from mine, and he was good friends with the CEO that was up here at this time. And at least once a day, you going to go up there and take a look at that position? This is a position that's open. Take a look at it. Sounds like a perfect match. If you don't like it, you can always leave. Excuse me. You can always leave and go back to go to law school. I don't know. Okay, I'll come up and I'll interview. So I came up and interviewed with the CEO at that point in time, and I didn't really take the interview all that serious. It was maybe more for the sake of satisfying my friend back in Fall River, and to out of a professional courtesy, because he had reached out to the CEO here. This position was open.
Right.
And vouched for my upstanding character as an individual. And so I was convinced that I wasn't going to like it when I first came up, but I was surprised.
Okay.
I was surprised by the people that worked here. I was surprised by the depth of their commitments to the community that they served. And I was curious to pursue it more. And so I came back for a more formal interview with the board chairman and I think probably the entire organization at that point in time. And so I was offered a position here. I committed to stay no more than 2 years. So, because I wasn't sure how it was all going to work out, but I said, I can make a commitment for 2 years. And so I committed for 2 years, and I stayed for 33 years, something like that. And that's how I got here.
Wow. All right. So let's talk a little bit about Exeter for a second,
Sure.
And then we'll come back to the organization itself. So since this podcast is being listened to by people from outside New Hampshire,
Sure.
who probably know about as much about Exeter as you did before you got here. I'm making you the temporary internet ambassador
Sure.
for Exeter. And Rockingham County. Sell us on the area.
Sure. Well, initially, as you can tell, I wasn't totally sold on the area, so everything was frozen over, and I decided I didn't want to come. And so, cycle forward 2 years later, and I come and I stay for 30 plus years. And so it is a unique environment to be in for a whole bunch of reasons. The state itself is small, relatively small, 1.3 million people in the state. And the seacoast itself geographically is kind of a unique area. It's got a lot of things that I like. I like to snowboard, so it's got mountains. I love the ocean, so it's got the ocean. It is a community that is intellectually precocious. There's a lot of very smart people that live in this community. There are a lot of people that are very committed to the work that they do, whether it's in healthcare or otherwise. It's a state that is still trying to find its way, in some ways, in a rapidly changing global economy and a global society and national society. It is deeply rooted in some of its very old traditions, dating back to King George, perhaps, and yet struggling to figure out how it plays a role in contemporary society, whether it's in education, in the case of UNH, and other educational systems, school systems in the state, in the case of healthcare, in the case of employment growth. It's trying to figure out how it can maintain a contemporary role in the growth of the state economy. It is imminently accessible. The legislative process is imminently accessible. Our leaders are imminently accessible. And every 4 years, every presidential candidate that comes to New Hampshire is imminently accessible. It's a fabulous place to raise a family. Boston is close by. It really is just a fabulous place to be. And for me, notwithstanding the geography, who you work with, your colleagues, really frame in many, many ways how rich a life experience you're going to have. You've got your family for sure, but you spend the 30 of your waking hours, at least sometimes, in the company of your colleagues. Mm-hmm. And so you combine a fabulous geographic environment with great colleagues to work with. That's why I've chosen to stay. And I've recruited executives from around the country. And the 30 plus years I've been recruiting executives into this organization, not a single one has left. Wow. And so they've come from everywhere. And so it is a unique place. Mm-hmm. Similarly, when we recruit physicians, most stay, few leave. And so it's got the right combination of factors, I think, that appeal to people that are looking for an environment that they can raise a family, raise themselves, grow, expand, and have accessibility to some of the brightest institutions in Boston and some great institutions here. And it's a great place to be.
All right. So they recruited you in 1981, and what was your first position? What
Executive Vice President. So I was Executive Vice President, and as a result of that, I served in executive capacity whenever the CEO was not present, but also had principal operating responsibilities for the ambulatory services of the organization as well as the support services of the organization. So that time, Exeter was a relatively small organization. I think we only had about 300 employees. I think we're somewhere around 1,700 at this point in time. Okay. And so it was in some ways, it was a smaller organization. You knew everyone, and they knew you. And in some ways, that made communication that much more intimate and direct. So it's become a little bit more complex. It's become more challenging as we've grown over the years. But it has not lost the values that attracted me here as an organization, which kind of ties into some of the questions you had about culture. It's retained an intimacy, notwithstanding its size, that enables people to communicate and stay connected as colleagues.
Great. What did you learn during that first 5 years or so that you were here that kind of prepared you for your next role, which was CEO?
Sure. That came pretty quickly. Well, I think when you come out of graduate school and you spend a couple of years postgraduate work, you think you know a lot. You think. And in some ways, perhaps more than other people that had gone directly from graduate school without spending time either in a residency or in a fellowship. In the middle of the battles, I think in some ways I probably knew a lot more than most graduate students coming directly out of the classroom setting. But I didn't have any idea how much I had to learn coming into this position. And so, and this was a relatively small organization. I left a much larger organization in Fall River to come here. And And so in some ways, I don't think I appreciated the total complexity of any organization, that no matter whether you have 100 beds or whether you have 1,000 beds, you have an amazing degree of complexity in any organization. You combine services with people and people with different backgrounds and educational disciplines, all trying to collaborate and converge on providing patient care in an environment that is probably one of the most regulated industries in America, with enormous uncertainty over the economics underlying healthcare. It created a degree of complexity, I think, that I did not fully appreciate on the one hand. On the other hand, what I came to appreciate is that leadership doesn't have to be necessarily complex. And I think being able to work in a small organization initially really caused me to understand the critical essence of effective leadership that can ultimately be multiplied over any scale of organization. And there are elements that are true in any leadership position, so that whether you're leading a team, platoon, or whether you're leading, 475,000 people in the case of IBM globally across, different countries, there are elements of leadership that ring true no matter what you're doing. And so I learned those here in a very intimate and direct way, and that was a real positive about coming here.
Can you give an example of something that you learned during that period?
Absolutely. The thing that people ask me about is, what are some of the most important leadership constants that you have to have? And there is no question. What struck me is that leadership is an incredibly lonely position at times. Not that you're isolated, because people will look at any CEO, any president, any leader, like, you're surrounded by people all the time. And I am.
Absolutely.
It's like it's nonstop. It just goes nonstop. There's times, when I go out for a run or I go for a bike ride, I don't want to hear anything. I don't want to listen to anything. But your decisions and the consequences of your decisions are very lonely decisions at times. And even in the instance where you're not actually controlling other elements of your organization, you bear the responsibility for those elements. And when something goes wrong, it's a very lonely time to recognize that truly the buck does stop with you.
Right.
So the thing that I learned a lot out of that is to be comfortable in that loneliness, to embrace it for what it is. And when there's a singular level of accountability, there's a singular level of accountability. And with that, a unique loneliness to yourself. You're alone with your thoughts, your decisions, with your consequences. And learn to savor that and learn to understand those feelings and learn from them. And so that was powerful for me. And, and I know one of the questions that you pose is, what are some of the more difficult decisions that you've had to make?
Sure.
They're all difficult.
Okay.
When you think about it, and I think the degrees of difficulty, maybe the more you make, the more sanguine you become. That wasn't all that hard. But when you step away from it and look at it, the consequences of any decision, small or large, are always significant. And so, given the fact that you're making decisions continuously, there are certainly degrees in which one decision has much more greater significance or consequence than another. But I rarely see a decision that has to be made that's a simple decision, And
okay.
it's,
at your level?
At my level.
Okay.
And so they all have consequences, and you need to understand what those consequences are. And in some cases, you will never understand the totality of those consequences until after the decision is made. And so your process, small or big, for making decisions is a continuous process of calculation, of assessing the risk, of assessing the benefit, to being able to do that in the moment, to be able to do that in a short cycle time, or in some cases to do it over a long cycle time.
Can you give me a specific example of a decision that you're talking about, so we get a sense of the scope of
Sure.
what you're talking about?
So let's, we make the decision, by way of example, we make the decision to buy a laboratory, a for-profit commercial laboratory we decided to buy. It was my predecessor, the CEO, said, we ought to buy this laboratory. And okay, why should we buy it? And so we kind of went through the analysis and made the decision that we would buy the laboratory and jointly acquire the laboratory with another health system, with another hospital. And so that decision, both in terms of the acquisition of the laboratory integrating our laboratory operations into a commercial enterprise, both here as well as at the other hospital, having to significantly restructure the laboratory, bring in professional management, and elevate that laboratory so that it could sustain itself, had a multi-year consequential chain of implications for our organization, all positive in many ways.
Okay.
And so it was a very successful decision to buy the laboratory. Cycle forward probably about 10 years later, maybe 12 years later,
Okay.
I concluded that we should sell it.
Oh, okay. So things had changed?
Things had changed.
Okay.
It was not necessarily a core competency of ours. The valuation of the commercial laboratory had reached a significant apogee, and it had become much larger than what we had contemplated. It was providing services in New Hampshire, Massachusetts, Hawaii,
Wow.
and it had grown significantly. And so we decided to sell our ownership interest in it, and probably got about a 500 or 600% return on our original investment, still maintaining a contract with the laboratory to provide services to the hospital's laboratory services as well. And so pretty significant consequential decision in terms of people, systems, other organizations. And then just as importantly, when you're at your high point, when you're doing the best that you can, having the courage to say, maybe we've reached the maximum limits and we don't want to take any more risk associated with the laboratory, and it's moving in a direction that's not necessarily within our core competencies. And to have that courage and insightfulness to say it is appropriate to exit a business. It's hard for a lot of healthcare organizations to leave something. We're creators. We create services for communities, and rarely do we abandon services or go in a different direction. So that is a great example of that. Additionally, we've made decisions on investments in technology. We've made decisions in investing in services. Somewhere in your questions there, you referenced the decision to joint venture, to enter into affiliation with Mass General Hospital for radiation oncology and medical oncology. Those are decisions that we make that have long-term consequences to our organization, and hopefully we manage that such that the consequences are all good and that it's beneficial to our patients. But in all instances, it involves people, it involves tens of millions of dollars of capital equipment and capital facilities. So the decisions are pretty significant. So that would be an example.
Okay. All right.
Just one or
two. Yeah. No, that's great. Let's talk a little bit about Exeter Health Resources.
Sure.
Okay, so it has three components that I've observed.
Principal ones.
Ones. The hospital, core physicians, and
home
the
care.
Rockingham VNA and hospice. So let's talk a little bit about the hospital. How big is the hospital?
Sure. The hospital, which is the original part of the company, that's what had existed here that's probably about 110 years now. It's 100 beds. It was 100. It was 100 beds when I got here.
Oh, it was.
Oh, yeah. It hasn't changed at all. There was great pressure on us to increase beds. I have a somewhat conservative view of investing in beds, largely because my view is that beds are expensive to build. You do need to have them. But I had a sense many years ago that the pressures to reduce hospitalization, reduce length of stay, would create a situation where we could have stranded capital, beds that are being underutilized. And so when you looked at some of the classic forecasting models for inpatient capacity, if we had applied those classic forecasting capacity models, we would have built another 50 beds, 150 beds. I didn't believe in those models given what I saw occurring over the horizon in terms of pharmacological, technological interventions that would transition a lot of inpatient care to the outpatient setting. Demographics were changing, and a lot of times the forecasting models are significantly biased based on historical perspective.
Right.
So we decided not to expand our bed capacity. We renovated, we invested in the existing capacity, and so it's 100 beds. Our length of stay is a little short of 4 days. 60%, close to maybe 60% of our revenue stream comes from the outpatient basis anyway.
Okay.
So it's a little bit of a different viewpoint.
Okay. All right. And core physicians?
Large multi-specialty group practice.
About how many physicians?
It's over 100 physicians. Yeah,
100 physicians and as well other kinds of
other providers. So probably a total NPs, nurse practitioners, physician assistants. I think they have a total of about 500 employees, somewhere right around there, 400 employees. I think all total providers, physician and non-physicians, probably close to 150 individuals. We have employed physicians for 20, 25 years. We've been doing it for a very, very long time. It's a model that I've believed in terms of a way of integrating physician services into the healthcare delivery system.
That wasn't common 25 years
No,
ago.
it wasn't common at all.
Yeah.
Not at all. And
it's becoming more common now.
Well, it is. Well, and there was also an extensive period of time in which health systems shed their physicians that they employed because they were losing a lot of money on them. And so there was a great buildup in the 1990s with health systems acquiring physician practices, just acquiring them without any rational basis of understanding why they were acquiring them, in part driven by some of the reimbursement models that were out there, particularly capitation that was out there. And so, but they didn't really understand what they were doing and why they were doing it. They didn't have a long-term viewpoint of it. And so as quickly as they got in, they got out as losses mounted into the millions of dollars. We have been doggedly pursuing the physician employment model because we believe that's a good way to integrate. We had anticipated that because of changing demographics, most physicians, at some point in time, not all, but most physicians would prefer to work in a corporate setting where the volatility is reduced relative to private practice or small group practice. The ability to deeply collaborate is enhanced because of investments in EMR that solo practices or small group practices can't make. And frankly, lifestyle choices of a whole new generation of physicians that are coming in that have a different view of what work is defined as. And so we've been providing physician services on an employment model basis, as I said, probably since, 1990, maybe sometime right around there.
Now, Core Physicians doesn't just have an office here.
It's scattered throughout Rockingham County.
Okay.
And my guess is I think maybe 14 office locations. I could be mistaken with that. We have 5, 6 principal ones and then smaller satellite ones, so covering all of Rockingham County.
Okay. And these facilities kind of drive workload into the hospital?
Well, they do. Well, they do. And other facilities. I mean, we don't. Our physician group, they admit mostly here. Many cases based on patient preference. They don't. A lot of cases, if we're out in a peripheral area and patients prefer to go to other communities, then that's where they would be admitted. The ability to care for patients that in an organization that has an interconnected EMR is pretty powerful.
Okay.
And so, and patients sense that as well. Patients truly appreciate an integrated EMR so that whether they're in the physician office or in the hospital setting, the ED, patients have frequently articulated to us that they can appreciate having a global view of their health status so that people aren't fumbling around to try to figure out who you are. And additionally, there are a lot of specialty services that we don't provide as a health system, and so those patients are referred elsewhere. And so we're scattered all over Rockingham County.
Okay.
Yeah.
And then the Rockingham VNA and Hospice. Tell me a little bit about that. How do we measure the
home care? Rockingham VNA Hospice was an organization that was in financial failure. They approached us about some way of incorporating them into us. At that point, I mean, home care has been a economically challenged industry generally. It kind of goes through these cycles of feast or famine based on kind of the political winds of reimbursement in Washington. And Rockingham VNA had a pretty deep history of providing home care services here as well as in the western part of Rockingham County and Merrimack County. And so, but they were in significant financial distress. So they approached us, approached me, we evaluated them, analyzed what changes would need to be made in the organization to make it viable. And so we integrated them as a affiliate of our organization. Gosh, that's probably now about, I'll say it's probably about 18 years ago, maybe right around there, 15 years ago. And so, 18. So it's been a long time, needless to say. And so our view about home care is that it would be a critical asset to any health system that is looking to find alternative settings in which care can be provided and depressurize the very expensive acute care setting. Hospitalizations. And so we're able to shorten our length of stay because we have a pretty significant outlet for that with home care. We had at one point in time also operated a 125-bed skilled and intermediate care facility, which we closed down. We operated that for a long, long, long time, but the economics of that became, you talk about decisions that are consequential.
Yeah.
The economics of that became so pernicious because of inadequate Medicaid reimbursement and declining Medicare reimbursement. In the sophistication of care that we provide to complex patients, we had to make a decision to leave that business. And so we did close that about 4 years ago now. So Rockingham provides a very sophisticated level of home care for patients.
What kind of things could a patient have done in their home?
Well, there's several things that can be done.
Or often
Hospice care
Okay.
can be done, obviously. A lot of care that's provided is to chronic disease patients, chronic diabetes, chronic congestive heart failure, chronic obstructive pulmonary disease. So you're dealing with respiratory support, you're dealing with infusion support, pharmacological support, and as well as post-surgical follow-up. And so we're able to discharge patients very rapidly from home, appropriately so, but rapidly from the acute care setting to the home care setting, knowing that we have a pretty sophisticated and competent nursing home care staff. If you don't have that, you can't make the discharge. And so frequently patients will linger in the acute care setting waiting for the opportunity to be discharged at home. And the home care setting in itself can be a challenge from the standpoint of the sophistication of the patients, the complexities of the family. There's a lot of challenges to home care as well. But it provides most people prefer not to leave the home. If they can receive their care at home, they would prefer to do that. And so we enable that.
Okay. So you took over as CEO after about 5 years.
Mm-hmm.
How did you grow into this role? So that was a long time ago. That's in '85, so almost 30 years ago. So how have you grown into this role? And I guess I would say, if you could go back to 1985 and talk to your 1985 self, what would you tell him? Hey, this is be prepared for this.
Yeah, exactly. I guess you're not well prepared for the unknown things that come at you, and they come from everywhere. And so, if you were to look at it from the standpoint of regulatory changes, the changes that have occurred in reimbursement, the changes that have occurred in technology, changes that have occurred in the way care can be delivered, and I'm kind of the person that I just expect change to come. It's part of what I do. And for me, I'm actually, in many ways, more comfortable in chaos than not.
Okay.
And so I can connect dots that people don't even see the dots. I can make connections. I can see patterns. I can see trends. And so for me, what might appear to be, complete ambiguity is not complete ambiguity. There's uncertainty, but there are pathways that you can see emerging, and those pathways represent choice points for you as a leader and as an organization.
Is that an important skill for someone sitting in your role?
I think it's a critical skill.
Okay.
You can manage by the numbers. You can lead by the numbers, but the numbers lie all the time.
Okay.
So if I followed the numbers, we would have built another
the extra
50
beds,
cube,
right,
and
they would have been
sitting
wrong.
empty.
Yeah.
So numbers are important. They kind of give you a reference point. It's probably the singular greatest creation of mankind is mathematics. It's such an interesting abstraction.
Mm-hmm.
And so there are reference points for our organization. But, you could look at, if you think about even digital computing, there's zeros and ones. That's all they are. And yet you think about the complex tasks that zeros and ones can perform if arranged in patterns. And so what I think as a leader is to be able to transcend the numbers. The numbers will certainly in some cases maybe reinforce your tuition.
Mm-hmm.
I'm a very intuitive leader.
Mm-hmm.
They can maybe cause you to pause. Kind of the hard quantifiable data causes you to pause and maybe to think a little bit more deeply.
Mm-hmm.
But I think a significant part of leadership is intuitive. It's emotional.
Mm-hmm.
Not to be emotional, but there's an emotional component to it, especially in healthcare where you're trying to understand the consequences of your decisions in human lives and communities. And I think there's a good part of it in which you need to know when to have risk on the table and when to take risk off the table. So I spend and I think a lot about things that may not be apparent on a sheet of paper. And so I abstract things from a lot of different parts of the economy, a lot of different parts of the political environment, from a lot of different areas. And I assemble them in my mind to a sight picture, a picture of what you see and how you envision the future, or how you envision even the opportunities that are going to face you today. And so I think it's very important to be intuitive, to be able to make connections to what might appear to be abstract things that at some point in time in the future converge and create opportunity or threats. To be anticipatory, I think those are really, really important. Any single leader, any single CEO can sit there and read a balance sheet, read a financial statement, kind of do the financial analytics that need to happen in any organization that generates revenue and has a revenue cycle with it. But it's a lot more than that. And for an organization such as healthcare, where it is powerfully grounded in people, it doesn't lend itself easily to automation for a variety of reasons at this stage. It is powerfully grounded in people, taking care of people, doing things to people, with all the frailties of human endeavor that are not easily mechanized, with all the uncertainties, and recognizing that no human endeavor is error-free, and recognizing people do things in the care of patients that also come from a deep emotional commitment to their profession. So I think being a CEO, being a leader in healthcare requires a lot of complex skills, but I think above them all is your ability to intuit, and your ability to anticipate, and your ability to be flexible about the future.
That sounds really interesting. I'm sitting here listening to you talk about that, and it sounds like your interest in history kind of comes back around.
Well, it comes back. It does. Oh, sure, it does. Yeah, history. Yeah. What do they say? You're doomed to report it, to repeat it if you're not, if you don't understand it.
But it seems like the kind of intuition that you would have gotten, or maybe the kind of intuition that you had, would have interested you in history to begin with. Maybe.
No question about it. You think about great leaders, and there's a lot of things that have in common. And so. Your ability to connect to the people that you lead is really critical. And I tell people this, and Exeter as an organization has had its ups and downs. I mean, the environment is remarkably challenging, and leadership is easy when things are easy. Sure, it's easy.
Right.
It's when it all goes south, when it goes wrong, and it is then that you really begin to appreciate how people look to a single person to assure, to find a pathway, to correct a situation, to provide an alternative to the position that they're in. And there's no one else that can do that at that moment. And so, and if you think about the great leaders who were able to execute on the opportunity that was presented to them historically, they were able to do that, And so whether it's Roosevelt, whether it's Shackleton, whether it's, some of the great military leaders of our time, who threw the playbook away and understood that they had to deal with what was presented to them and improvise. And, it's really quite striking. And I really think about anybody that's in a official capacity of being a leader. It doesn't mean necessarily that they are a leader. And opportunities are thrown your way. They come your way to give you the opportunity to be the leader. And you have to choose.
Okay. Let's talk just for a minute about governance. Exeter Health Resources is a nonprofit entity.
Yeah. So
you have a board. Talk a little bit about the board, your relationship with the board.
Sure. So the board, the board, most healthcare systems, as you know, have a governing body. The board for Exeter Health Resources is a relatively small board compared to what you might see in some healthcare organizations. It's about 13, 15 people. And it has several critical responsibilities. Number one is to establish the policies that govern our institution, to ensure its viability, its sustainability from an economics perspective, to ensure that it provides quality care that our patients, customers have come to depend on, to ensure that we are conducting ourselves in an ethical way, in a compliant way relative to regulations and laws, to evaluate leadership, most importantly the CEO, and ensuring that the leadership is present to execute on those policies and to provide guidance for the board to think about as policies are formulated. And so we work very hard, work very closely with the board to ensure that the board is diverse in its viewpoints and has a skill set that represents our future demands. And so we have board members that periodically turn over as we look for the skill sets that we think are important for a governing body governing in 2016, 17, and 18. And so continuously evaluating how do we ensure fresh sets of eyes to consider our organization, different perspectives. And as I said, to also encourage, embrace diversity of thought, intellectual diversity of viewpoints. And so that creates a challenge for leadership, CEO. I've been here for 35 years, and I can't tell you how many boards I've turned over that time. And yet, I think what's important is that as I work with the boards is to continue to sustain our values as an organization when we look at someone, when we evaluate a board member. How do they represent or match to our value system and the things that we hold as important to our organization? And that's no different than when you evaluate anybody that you bring into an organization, in a leadership position or in the board position. How do they advance your capabilities as an organization? How do they syncopate with your values as an organization? And how do they bring intellectual rigor to the decisions that loom in front of you? And we've been very fortunate over the years to have just amazingly competent board members, just amazingly competent.
Are they all drawn from the community?
Yeah, they are.
Local community? Okay.
Local community being, within 30 miles.
Okay, yeah,
Yep.
sure.
Yep.
You have a unique viewpoint, having been here for an extended period of time.
Mm-hmm.
You have been able to kind of stay ahead of the wave in a lot of ways. You made it through some major kind of seismic changes. You mentioned, the shift to prospective payment.
Yep.
Big shift to outpatient care. You saw that coming. You avoided it, or you
embraced
embraced it rather than avoid it. You
Yep.
avoided making the mistake of continuing in the old way. And now you're kind of in the midst of the adjusting to the ACA and the implications of that policy change.
Yep.
So kind of talk about some of the big changes that have happened during your tenure and kind of how Exeter has kind of thrived on them.
Well, I think that's probably part of the reason why I've stayed here. It's like I said, I thrive in ambiguity and chaos. At some point in time, you got to make a decision, but that stimulation of uncertainty and volatility creates opportunity all the time. It just does, and it's just a question of what pathway you see and which one you choose to take. And so there are a lot of regulatory changes that certainly have happened, whether it's DRGs, whether it's APCs and the like, and obviously now the Affordable Care Act and all the sequelae that come from that. And some of the changes that occur are done to you. It's like taxes, it's like you pay taxes. And so DRGs, you got DRGs. APCs, you got APCs. ICD-10, you got ICD-10. It just goes on and on. And so there is a expected and predictable regulatory burden that has consequences to us in terms of the changes, but you have to take those in stride. It's kind of part of the scenery, I guess. And so I have enormous intolerance for people who complain about all the changes that are happening. And I always think about, well, what's the alternative to changes? Horse and buggy? I just don't know what the alternatives are. And so for me, the speed of change is actually striking in some ways. As an industry, however, when I think about the healthcare industry, if you think about the changes, certainly in my career, I actually, and maybe I'm just becoming, diminishing the significance of some of the events that happened in the 70s or the 80s or the 90s, and I'm sure in the moment they were probably quite astonishing to me. And yet when I look back, in some ways it's an industry that has remained relatively unchanged. It's new facilities, a couple of new imaging things here and there, PET scanners, CT scanners, or MRI scanners. But in a lot of ways, it's remarkably the same. We got computer terminals and we got EMR, but in a lot of ways, the work that we do here isn't significantly different. It's work that has existed. In some ways it may have been automated as a result of emails and, and networks and so forth. But the front end of my career, where a lot of people think a lot of change happened, I've come to conclude that it's not going to be like anything compared to the change that's going to happen, which I do think is going to be deeper and more transformative. And so, healthcare, has been on this really remarkable ride. When I started in healthcare, when healthcare spending was going to hit 10% of the GDP of the country, all hell was going to break loose. We wouldn't sustain it. 20% now, $3 trillion a year, there, plus or minus. And so healthcare for the longest period of time has enjoyed an enormous economic advantage as it has garnered resources from other sectors of the economy. And who can't thrive on compound annual growth rates of 6 to 8%? I mean, Apple thrives very well on those kind of compound growth rates. The auto industry is pretty content with 1 or 2% compound growth rate on units, sold on average. Healthcare, so it's just amazing. I mean, it's just been great. Population grows, they want more healthcare, there's more technology, fee-for-service reimbursement, Social Security Act, Medicare, Medicaid, commercial insurance, employer-sponsored plans. I mean, really, it was an amazing period in which I think about, what's gone on in terms of QE2, with the stimulus into the economy. Why would we why are we surprised that we're at $3 trillion a year, right?
Yeah.
So I think about that, and it's been a period of certainly changes, but not kind of the deep transformative change that really sets the industry in a very different direction. I think we're on the verge of that.
So what's going to drive it? What are the things?
Well, there are many factors that are driving it. In fact, one of the, as I presented to one of the UNH classes a couple of years ago, and I put a picture of a Chinese ministry official up there. I said, "Do you know who this guy is?" Nobody knows. So he's one of the most important factors in the United States economy. He was the Chinese finance minister. He makes decisions on how much treasuries they want to buy, how much U.S. securities they want to buy, how they want to invest in the United States. He said that man alone, being somewhat facetious, probably has more impact on what's happening in healthcare than anything else that you can imagine. It's not that alone. I was using that more for hyperbole, but. So whether you think about the global interconnectedness of economies, you think about the United States industry that historically has been largely insular from that, and as a result of that has been able to afford the great benefit expansion that has occurred and the wage expansion that had occurred up until probably the last 10 years. And the United States still is the world's largest economy, but that's changing. It's being globally challenged as a dominant economy. We are significantly in debt. Now, there's a lot of views as to whether that's, good or bad. Technologies, truly disruptive technologies, which enable the consumption of healthcare to be displaced regardless of geography and time, is pretty significant, and that is only starting to take hold.
Telemedicine kind of thing?
Classic example.
Okay.
Telemedicine is a classic example. Your smart... Take your smartphone, 6 billion transistors on a single chip on your phone. It's very intelligent and can change a lot about the way healthcare is consumed and the way it's evaluated.
So you think mobile maybe is going to be a major?
It already is.
It already is.
Swipe your card, $40, you get a physician consult in 90 seconds. So transformative. Anytime you can change the time and place of consumption, it's really a remarkable event. It really is. And if you think about healthcare, it's always been predicated on a physician office, 9 to 5, and that's where you go. And if you get in, within 2 weeks, you consider yourself lucky. So I can't quite say we're like the cabbies out there fighting against Uber, but
right.
It's going to be. I think it's going to be that transformative. And I think even beyond that, however. And that's just one aspect of it. The deep investigative resources that have gone into understanding disease at the cellular level, at the molecular level, at the kind of the protein level, and the work that's going on there to truly understand how disease proceeds, how personalized it is, and how to intervene with disease. is going to find expression over the next 10 years. It's going to be pretty startling. How we afford that is another question, but nonetheless, it's emerging. And so I kind of look at it as a convergence of many, many macro and micro economic considerations, enormous societal implications, technology, and it's like, when I talk to people, I say, why do you think healthcare is not going to be transformed like virtually any other American industry? Why do you think we're going to be immune? Why should we be immune? Transparency of data. We just had this discussion this morning. Patients, shortly, if not by federal law or otherwise, by absolute demand, will have access to every single piece of information regarding their care within a day, 4 days at most. And some institutions, they're making it available immediately. So what has happened in some ways is that healthcare has been able to regulate its own destiny. One might argue to ensure its destiny through the collection, dissemination, and control of information. It's the ultimate definition of a profession in some ways. That's being shattered. And so when you have an empowered consumer who is knowledgeable, and if they're not that knowledgeable about their health care, are enabled through expert, highly powered, driven algorithms driven by the Watsons of IBM world, it's an amazing thing. It's an amazing consumer-driven healthcare economy, and that changes everything.
So consumer-driven, you think, is
I do. I think it's going to be a very, very powerful factor. We all want to be taken care of when we're sick.
Right.
We all want to go someplace, and we want to be taken care of. But when you actually look at healthcare consumption, is significant. An overwhelming part of healthcare resources go to a vanishingly small part of the population. The vast majority of the population doesn't really consume a lot of healthcare until until the later years of their lives. And so in that period in which they are, not acute care consumers, they're not chronic disease healthcare consumers, they're relatively well healthcare consumers. They consume healthcare, and they're mobile, and they can be enabled through information. And as a result of that, their expectation of the delivery system changes. What do you mean I have to wait 2 weeks? What do you mean I can't get my CT scan image tomorrow? What do you mean I won't understand what I'm looking at? What do you mean I have to wait for you to tell me what's wrong with me? Why? So, we have, and I made this comment to a group this morning, we have always articulated as an industry, well, the medical record is always the patient's. Well, when you think about it, when in the old days, the medical record was a paper record, it was in a chart, and it was kept in the nurse's station. It wasn't kept at your bedside so you could read it, right? That was kind of the penultimate insult to the notion that the patient is the owner of their medical record information, to where we are today, where there will be ubiquitous and universal access to that information by the consumer, by the patient, as it should be ultimately. That changes things. So I kind of look at any one event, yeah, that's kind of intellectually interesting. I'm not sure what it means. It is, I think it's in any industry, it's about conversion. It's conversion about factors that are disparate in some cases, obvious in other cases, to get to a tipping point. I think we're getting there.
Okay. Can we talk about the strategic planning processes you've used, the formal processes that you use today versus, say, what you started using? How have you changed your style in that over the years?
We have changed over time. When I first came here, we were an organization that contracted out to the great consultancies of the world to do our strategic planning. It would produce a document after 18 months of arduous, at times agonal processing of data and demographics and committees and board committees, and it would be delivered, it would be bound, it would be perfectly crisp paper, and it would be absolutely obsolete the day it was delivered. But God, we love those plans. Hundreds of thousands of dollars later. When I got here, I saw these plans stacked up in the hospital, and I was like, that's not me. And so we have historically, since I've been here, have used a ground up, top down, bottoms up combination of planning that is very organic. It is very short cycle planning. I don't have a 50-year view. I don't have a 10-year view. I do have a lifetime view of adaptability. And so what I've tried to do with our organization is to have a planning process that stimulates calculated risk-taking, that enables absolute flexibility, that has a relatively short view from the standpoint of how we plan. So the degrees of probability, the degrees of certainty obviously attenuate as we go out further.
Sure.
We view ourselves currently in a continuous planning process. There is no discrete, there's no ending or beginning. We're always looking at that. It happens to be indexed because we have a fiscal year. We have to put together a budget by regulatory requirements. And so serendipity, a lot of our planning kind of indexes to our fiscal year. But the reality of it is that we are in a continuous planning mode. And we tend to stretch out our viewpoints to 2016. In this case, we're doing 16, 17, and 18. There are, however, events that lead us to have to make longer-term capital investments. So if we decide to invest in radiation therapy, we put a new radiation therapy in, $10 million later. You have long-lived assets sitting there that you have to have a little bit of a longer view than a 3-year story as to how it's going to be used. Mm-hmm. And so we do recognize that for major capital investments, we have to stretch our legs and kind of look at what's the relative risks of demand for that particular service or product that we put in place that has a long-lived asset base, that has significant resource commitments, and have to make that judgment as to what the relative probabilities of success 5 years, 10 years from now will be. If, for whatever reason, we miscalculated in that, what's our exit strategy? What do we do if we've made a wrong investment decision there?
Is that part of your adaptability?
Absolutely. We built a Synergy Health and Fitness building about 15 years ago. It's comprehensive rehab services as well as a public fitness membership, and I looked at that, and it was the right thing to do, but I knew if it was the wrong thing to do, that we could easily exit that business, the fitness business, which one could argue was a little bit further away from our core competency, but was still tethered to that core competency of rehabilitation services. That if our calculus on membership-driven services was such that the marketplace couldn't support a premium price for it, which we did construct a premium price, we would have another alternative use for that facility. We exited the premium price membership facility, service, health, fitness facility, and we're renovating that facility to house consolidated musculoskeletal physician specialties in there. So, adaptability. Longer term investment from a planning perspective for sure, but what if you're wrong? What's your alternative?
So you try to structure into any kind of longer term commitment a means of adapting to the change.
Or at least minimally.
If it doesn't work out.
Right. Minimally envision another possibility. It's a little bit harder for radiation therapy. You got a million tons of concrete sitting out there. Radiation bunker, maybe fallout bunker. Right. I don't know. It's a little bit
not
more.
A lot of demand for that either, but hopefully it won't ever be.
Right. So it's a little bit more complex. But we do use Hoshin planning here as a Hoshin deployment. It comes out of Japan. It's we've integrated that with our lean processes. You saw some of that up there. Mm-hmm. And I don't know if you're familiar with Hoshin planning.
I'm not actually. It's lean, but not. Yeah,
okay. Well, it's a way of deploying a strategy throughout your organization. We're into the second year of that, and it's kind of interesting to see how that works. So we don't make any pretensions about having the grand solution. I can't tell you how many countless Harvard Business Review articles I have read about planning, strategy planning, what works, what doesn't work, how to do it, and they've only done nothing more to convince me that there is no right way of doing it.
So Hoshin planning?
Hoshin.
Okay.
Yeah.
Tell me a little bit about that.
So it's a way in which we create alignment between our principles, our values, our overarching strategic goals, the tactical expression of those goals, and it graphically displays those goals and enables us then to subsequently disseminate that into the organization and have the organization at lower levels provide feedback, input, and modification to those goals. And so it's kind of a cyclical process. It's constant feedback, and when you bring the elements of your Hoshin, your key strategies, your key action items that you want to be taking action on, and when you bring it down to lower levels, different levels of the organization, it's called spinning. It's kind of interesting. It's it's a Japanese view of planning. Mm-hmm. For us, what we like is it provides a relatively simple graphical way of tracking and identifying and linking up our overarching goals, our values, our tactical intentions, and with kind of the measurable objectives that we're going to establish for it. So
And it enables you to push that down to the front line.
To the front line. So when you're sitting in if you're sitting in a department in a remote physician office and you see this Hoshin diagram, it's not so much about the diagram. It's about the connectivity of mission, strategic intentionality, and what we're doing here today.
Okay, great. Let's transition and talk kind of specifically about leadership, and then I'd like a little bit about mentorship. How would you kind of encapsulate your leadership philosophy? I mean, we've talked a fair about it now, but if you put it into...
If you were to come to one of my management meetings, you'd think all chaos had broken out, at a meeting. So I like loose, tight management. I guess that's maybe kind of the best way to describe it. I hire competent people. I provide them the support, encourage them to take the risk, encourage them to think differently than me, to push me, cause me to see things differently than the way I currently see things. And so I tend to place competent people in their roles, align them around our principal vision, our mission, our key strategic objectives, and I let them go. Truly. So there's a high degree of autonomy amongst my management group. There is obviously coordination because we have to function at a very coordinated basis. We are increasingly more integrated in what we do than disintegrated in what we do. And yet I don't attempt to orchestrate for them the understanding of what their key roles and responsibilities are. They need to know what their key roles and responsibilities are. We create an environment in which they can create naturally forming collaborative bridges, formally, informally. There's a lot of matrix management that occurs here, between people that have formal reporting relationships to each other, bridging over to other areas of the organization that they don't have formal reporting relationships. Leadership for me, as I said, on a singular basis, on an individual basis, what do I think the organization asks me to do? I think they ask me to provide principled guidance, support, ethically driven decision-making in our organization through role modeling. I look at, and we've faced many, many challenges in the organization. We always come back to what's the right thing to do. And frequently the right thing to do places you at individual jeopardy. It may place your organization at financial jeopardy, but at the end of the day, we care for people, and you have to always make the decision what's the right thing to do for that patient, for that family, for this community. And we're unswerving in that commitment of always doing the right thing. We talk a lot about our true north as an organization in terms of our orientation to those principles of high quality care, sustainable health care, ideal patient experience, and ensuring that when patients come here, they receive the very best care that we're capable of providing to them.
Are those the values of the organization?
Yep, see them anywhere.
Okay.
Everywhere. Right. They're everywhere. And I think as leadership is frequently characterized as functioning in the gray areas. And a lot of times there are a lot of things that are gray, in terms of either regulatory interpretation, legal interpretation. What does this mean? What do you think that means? I think our laws in this country are purposely written for the sake of being black and white, but over decades of interpretation, they seem to become gray. And so we recognize that there are things that are, in many, many cases, they may be gray. But as a leader, you always have the intuitive sense as to what's right, no matter how gray it is. You just know that. And I look for that in people, just to know what's the right thing to do here. And if they're uncertain, let's talk about what we think the right thing to do is. Leadership, when I think about the board, what does the board look for me to do as a CEO is to try to understand the operating environment that we're in today and what we might be in tomorrow, and create a pathway for our sustainability today going into tomorrow. What is that pathway? What does it look like? What investments do we need to make? What kind of people do we need to have? What shouldn't we do? And so they look to me to do that. And so I kind of view myself, not quite like the kind of the harried coach, running up and down the sidelines of a football game, because I'm looking at them, but sometimes when the play starts, it's out of their hands. So what do? They recruit good people, they make sure they're competent, well cared for, there's a strategy, there's a tactic, there's a plan, and then the game begins. But what doesn't change, it can't change, is your confidence in the people that you hired, and their adaptability. So I can't say I have an expressed leadership philosophy. I don't know if I'm that smart. but I do know what to do and when to do it and what the right thing is.
Okay. One of the important roles of a leader, of course, is creating a positive culture. How would you describe the culture here at Exeter, and what do you do to try to cultivate it?
Yeah, I'm asked that a lot. I'm asked that a lot by people we hire. What is it? A lot of times they don't quite say, what's the culture? They'll say, well, what is it like to work there? Same thing in some ways. And I kind of reflect back as to why have I stayed here? Have I simply escorted the culture that was to the 21st century as a leader? Maybe. Have I changed it in any way? I don't know. But I certainly think about the values that we have as an organization. We are a deeply caring organization, and a lot of organizations say that. We are, amongst ourselves. Most of us receive our health care here. And there is nothing that creates a more intimate connection to an organization than one that you work in, that you turn to help you if you're dying, or to help you when you're really sick, when you have your colleague take care of you. There is nothing like that anywhere. And so it's really quite a remarkable experience. And, coming as you do from the military, there are those instances in very close team operations where, one person thinks, the other blinks. They're functioning, they're syncopating. The mutual dependency is so intimate, It's kind of like that here, spread out, over a very large organization. And so the culture here is one of intimacy, respect. It is one that doesn't suffer fools well. You've got to be on your game here. Physicians sense that when they come here. They're surrounded by really smart people who are always pushing the envelope to do things better. And so you really got to be smart to work here. Just have to be. It's an organization that encourages curiosity. I would like to think it's an organization that encourages dissent. Someone somewhere.
How do you ensure that it encourages dissent?
It's hard. It's right? Real hard. We survey our employees, and a lot of times we get feedback that this is, I'm afraid to speak up in a particular department, and I'm like, how is that possible? Why did that happen? How do you ensure that what you believe to be true in your own mind is in fact true on the ground? We do survey. We do a lot of surveying of our staff confidentially to kind of get a sense as to what we call alignment with those values. And where there is not alignment, why is that happening? Is it leadership? Is it communication? What's happening in that unit to cause someone to say that I'm fearful to express dissent? And
that's dangerous in a
healthcare environment. It's very dangerous in a high reliability environment, in a kinetic environment. You know that in the military. It's dangerous in healthcare, where the slightest thing that goes wrong, not because of anyone's intentional commission, but it's prone to human error. And another set of eyes, another willingness to speak up is a critical factor for ensuring safety. And that's what drives us in this organization deeply, is this notion of patient safety. And so you've got to have an environment where anyone at any given time can say, wait a minute, what are you doing? Whether it's someone sitting at a leadership meeting with me and I think we ought to do this as a strategy. And if they all sit, all 13 of my executives sit there and nod their head, I know there's something wrong. There's got to be a different viewpoint of the world. So it's a critical role, I think, of the leader to sense that, to survey that, to understand what that means. And as I said, in an environment that demands high reliability, such as healthcare, dissent is a critical part of safety. And so that's something that we work very hard on. But
so if you get that kind of feedback from a survey, what do you do? How do you respond to that?
Well, usually it's like people's, it's always interesting. It's like, really, is that possible? Because we're not like that, right? Isn't that the leadership? Well, all the time we say that. Yeah. That can't be us. Is that us, really? And so you've got to move beyond that to recognize that, if you have parts of your organization that are not aligned with those very important principled values, you need to understand why. And we work very closely with the management on that unit to try to understand. Well, tell us what's different here. What's happening? What do you do from a communication standpoint, verbally and non-verbally? What's the operating environment like? What are the colleagues like there? And so while we have a culture here in our organization, there are microcultures everywhere, you
Sure.
know, and so it's, you think you're dealing with a homogeneous organization that believes it has a unified culture, but in reality there are microcultures everywhere, shift to shift, unit to unit. It's really quite striking. And that is good in some ways, and yet nonetheless there's got to be an overarching connection to the principles of the organization. So we do a lot of diagnostics on that, where if there's something going astray, we do a lot of intervention, training, working team building with groups, trying to understand what is causing a disconnect from our overall principle values, and that's nonstop.
Let's just finish up on talking about mentorship a little
Sure.
bit. It sounds like you had somebody looking out for you at the beginning of your career a little bit.
I did. Well, nobody officially.
Okay.
When you posed the question to me, did I ever have an official mentor?
Yeah.
And I really didn't. I'm a student of leaders, though. Contemporary and past. I even today, I've been doing this for a long time. But it always surprises me the way other leaders behave, good or bad, and there's always something to learn.
Yeah.
And it's not just in the healthcare industry, it's throughout all industries. How do people deal with uncertainty? How do they deal with catastrophe? Whether it's the BP oil spill in the times of crisis, or failure to grow earnings or revenue in the case of a Yahoo CEO, or someone dealing in a healthcare crisis coming out of an adverse patient event. You'll learn a lot by what they do and what they don't do, and try to juxtapose yourself into their shoes. What would you do? So I do that continuously. I've had the opportunity to work with board members who are very strong leaders in their own rights. And in my own encounters and my own work, I've always learned from all the people that I've worked with that are strong leaders, not so strong leaders. You always learn something from them. But was there someone who actually took me under their wing and made me a project of theirs?
Yeah.
Sometimes I wish that was the case,
Yeah.
I kind of go back to the sense, sometimes leadership's kind of lonely.
Yeah.
But I sought people out. The gentleman who directed me up here was a person who, would always make it a point just to, he wasn't mentoring me. He probably didn't think that, but I took it as that in terms of asking me about what I thought and what I did and what I was doing. And so it's we've not had that. We try to do that in our own organization, which is probably your follow-on question.
Yeah.
Mentoring, maybe because I haven't had as much of an opportunity, I'm very keen on that.
Okay.
Of how do you mentor someone? How do you consciously and subconsciously track them and engage them and spend time with them? On the clinical level, we have very formal mentoring programs.
You do?
We do. Yeah, absolutely.
Outside of an official training program, like they're a resident or something like that.
No,
it's still...
you're new to our organization and you're a clinician, you're going to get mentored here in terms of who we are, how we work, things that we do, things that we don't do, why, someone to go to in case, you need help.
Yeah.
We also do that for our leaders as well. So we do try to mentor and to create opportunities for that. And, we've had formal programs for leadership. We've had informal programs. We've kind of cycled through it. We've had a relatively stable leadership group in this organization for a number of years. But when new managers come in, they are connected with other leaders in the organization. They're tracked so that they're never out there alone in terms of how you're doing. And as an individual, there are people in the organization who I have a particular interest in because I see them as high performers in the future, that I take a particular interest in ensuring that they are growing and developing. So that's kind of the way we do it.
All right. What about professional associations? Which ones do you belong to, and what would you recommend?
Well,
to people who are interested in healthcare administration.
Yeah, and so there's kind of the before and the after. In the early stages, I think I was a member of every professional association that you could shake a stick at.
Okay.
So as American College of Healthcare Executives, as part of the New England Planners Group, I mean, it went on and on and on. And I'll be honest with you, at that early stage, I struggled with identifying with them, what they thought and how they viewed the world. And so increasingly I found that the thinking there was not kind of thinking that I had about healthcare in the future and where we might be going as an industry. And so they became less and less intellectually stimulating to me. And so one by one, they kind of dropped out. And
Okay.
so where I moved from there is I got engaged in a variety of different board roles in other industries, which I've enjoyed a lot, insurance industry and on the industrial side of industry. And so right now, I'm not a member. God, they're going. Oh no, okay. They'll strike me in the rear end, I'm sure. The American College of Healthcare Executives. What do you mean you're not a member? No, I haven't been a member in decades.
Okay.
So
not a strong value there. But one thing that I know our program is very grateful for is you take an intern from our program every year.
Two.
Two.
Now,
is it? Okay.
Yeah.
So, what are you looking for when you select an intern, and what does a successful intern do when they're on the job with you?
Yeah.
This is a little special advice for my students.
No, not at all. And actually, we just brought 2 interns in, just made that decision a few weeks ago. I look for people, interns, individuals to come into this organization that are really intellectually curious and willing to take intellectual risks. They are given an opportunity here to interact at a very high level with parts of an organization that they may not normally get a chance to do if they stay in the healthcare track for years. And I want them to see the organization in all lights, good and bad. And I want them to draw observations and conclusions to them that we can intellectually challenge. What do you see? What do you think you saw? What do you think it means? And so the first prerequisite is that you've got to be able to see, your powers of observation. And it's not just, seeing one box move to another box, but in the context of your educational experience and what you've learned in theory in class, what do you think you saw, what was going on there, or what we're doing as an organization? And so that's really important. Self-direction is really important, and they need to be self-organizing. We do provide support for them so that they don't totally drown in a big ocean or what might be perceived that way. But self-organizing, confidence in oneself, the ability to communicate in a powerful way, in an articulate way, both verbally and in writing, is critical. And I guess probably beyond that is to develop comfort in oneself that you're coming into an organization that is affording you enormous opportunity to learn. How do you take advantage of that? Not that you use the organization in a pejorative sense, but how do you take advantage of that? And how do you peer around the corner? How do you dig a little bit deeper than someone else would normally dig? So if you've got 15, 20 minutes with an executive and you kind of covered typical questions that you would have, how do you go off the grid a little bit to understand a little bit more deeply their vulnerabilities or what they do or the risks that they take or the concerns that they have about leading a function? Do you know how to do that? Do you feel confident doing that? So we've been fortunate having generally students, interns that have come through that have been able to do that. And they've got to contribute to us. We want them to contribute to us. And I tell them that way. I say, tell them that you're getting paid for your summer's time here. I want you to give me a work product, your best work product. And I'll help you choose what that's going to be, but ultimately it's going to be your choice. It's going to be your work product, and you're asking a CEO to judge that. And so I want value for my money. I want you to produce value. Yeah. And some of the work that's been done has been startlingly good. Last year's work was outstanding.
Good.
And it's challenging. And this is a problem that I think just is kind of the structural problem with it is that educationally they're not in a lot of places that they need to be able to form conclusions and insightful observations about what they see in healthcare. They're just developmentally, they just have not been exposed to that. And so, and I enjoy...
That's part of the process.
That is part of the process, exactly. And so, a lot of times we, whether it's on health policy issues, economic issues, governance issues, leadership issues, I always go through a process of kind of feeling out how much of this is real life experience that you've had, and how much of it is theoretical, and how much you just don't know. And that's just part of it. There's no question about it. And so, and the organization, I particularly, but other people, have enjoyed having interns that are precocious, that kind of ask those questions that always cause you to pause and go, that was a good question. We all like that.
Yeah.
We all like that.
So, kind of in conclusion, what advice do you have for someone thinking about going into healthcare administration today? What education should they pursue? What kind of initial jobs should they be looking for?
Yeah, I just had a long conversation with one of the interns from last year, just a couple of weeks ago, as they were sorting through directionally where they want to go. And they were most interested in how I got to where I got to, and almost everyone is, and like, well, how'd you do that? And I'd like to say I had a grand plan, but as you can see in this interview, I didn't have a grand plan per se. What I tell them is that, generally I'm a person that'll go through a door. Just am. I have a view that there are so many opportunities, as long as it's not life-threatening, and you can assess that, but my tendency is to go through a door without necessarily a clear understanding of what the destination will be, but I always have a sense directionally of where I'm going. And so at this stage of their career, I encourage them to go through doors, and don't get so structured around a destination that you never get your trip started. And so their healthcare is a remarkably diverse opportunity for employment. It represents an enormous opportunity. It's $3 trillion a year we spend. You can't find a place there to work, and so don't get wrapped around conventions. I need to, get my master's degree. It is absolutely helpful. There is no question about it, especially if you can get it in a very rigorous program. It will help in that rigor. But I always tell them, go into the program mature. Go into it mature. Knowing a little bit more about life and experience, it'll just enrich in your graduate studies. But, so whether you go in the pharmacology side, you go into the biotech side, you go into the actual delivery side, you go into the policy side, you go into the insurance side, you go into the physician side, all of those are great opportunities. And one will lead to another opportunity, have a sense of what your destination is, and be surprised when you arrive there. There is sometimes they just kind of get this mental model constructed that I need to do A, B, and C to get to D, and then I can get to where you are, Kevin. And I don't think it's that way anymore. It wasn't that way for me. Right. I could have easily been somewhere else than sitting here talking to you today. But I always, like I said, I always have a sense of, directionally, kind of where do you want to be going? You'd be surprised when the opportunity, stares you in the face. A lot of people don't even see it. And the other thing is, I tell them this all the time, is that you just never say no to opportunity. You just never say no to someone who you're working with who asks you if you can do something more for them. So we've hired, I can't tell you how many interns into this organization who've had stellar careers here. And, and they have been eager to take on more responsibility. When I was asked to be the CEO in this organization, I was 3 years out of graduate school. What did I know? I didn't say no. I can figure that out. Yeah. I've always I can figure that out. I have enough of a common understanding of what it means to run an organization, I thought, that I could do it. And so when the opportunity is presented to you, take the opportunity, get the experience. You can parlay it and you can do something else somewhere else. Remain true to your values. What are your values? So that's why I always kind of advise them.
That is great advice. Thank you so much for being a part of the Health Leader Forge today.
I've enjoyed it. Enjoyed the conversation.
You've been listening to the Health Leader Forge, a production of the College of Health and Human Services at the University of New Hampshire. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll see you again in about 2 weeks.